So the first one is the EBC-TCG meta-analysis of aromatase inhibitors versus tamoxifen in premenopausal women with estrogen receptor positive early stage breast cancer with ovarian suppression. So we know that for early stage hormone positive breast cancer, tamoxifen reduces the 15-year breast cancer mortality by 30%. AIs are more effective than tamoxifen for the postmenopausal women, but are ineffective if used in premenopausal without the ovarian suppression. So what this meta-analysis did was it took the individual patient data from 4 randomized trials, the ABC-SG12, SOFT, TEXT, and the HOBO, and did a comparison of AI versus tamoxifen with ovarian suppression. So the baseline characteristics were noted. Primary outcomes were the breast cancer recurrence, breast cancer mortality, death without recurrence, and all-cause mortality. After a median follow-up of 8 years, it was concluded that the rate of breast cancer recurrence was lower for women allocated to an aromatase inhibitor. The benefit was seen in years 0 to 4 with a significant p-value and 3.2% absolute reduction in the 5-year recurrence risk. There was no further benefit or loss of benefit in the years 5 to 9 or beyond 10 years. The distance recurrence was also reduced by AI. No significant difference was observed between the treatment arms for the breast cancer mortality, death without recurrence, or an all-cause mortality. So if we see the forest plot here, the ABC-SG12 study did not show the benefit of AI, while the TEXT SOFT HOBO did show the benefit. Apart from that, irrespective of the age, the hormonal status, nodal status, the HER2 positivity, the benefit was seen. There were definitely more bone fractures with AI as compared to tamoxifen, but the non-breast cancer deaths and the endometrial cancer were equal and rare. So the authors concluded that using an AI rather than tamoxifen in premenopausal women with ovarian suppression reduces the risk of breast cancer recurrence, but we need longer follow-up to assess any impact on the mortality. So my interpretation is that for this group of women, definitely a longer follow-up is the key to reaching any meaningful conclusions. All 4 trials included distinct patient populations with a variable risk of recurrence. There was no benefit of AI in the ABC-SG trial, but there is no explanation, and it happens to be only by chance. When we are comparing an AI with tamoxifen, we have to consider the individual patient level QOL, which is of utmost importance. Coming to the study 2, this is the 20-year follow-up of the Stockholm trial, which assessed the long-term endocrine therapy benefit in premenopausal women with breast cancer. So this trial was conducted between 1990 to 97, where 2 years of goserelin, tamoxifen, combined goserelin and tamoxifen or no adjuvant therapy was compared in a randomized fashion. 70 gene signature identified genomic low risk versus high risk, and a special time-flying flexible parametric modeling was also used to assess the risk of recurrence. So it was seen that goserelin plus tamoxifen or tamoxifen, all of them were superior to the control, which did not receive endocrine therapy. The genomic low-risk patients benefited with tamoxifen, and the genomic high-risk patients benefited with goserelin. The increased risk from addition of tamoxifen to goserelin was also seen in the genomic high-risk patients. Moreover, long-lasting 20-year tamoxifen benefit was seen in the genomic low-risk patients, whereas the genomic high-risk patients had an early goserelin benefit. The authors did conclude that these patients did have a differential treatment benefit based on the genomic characteristics. Combined goserelin and tamoxifen did not show any benefit over the single treatment, but a longer follow-up is required. So this trial was conducted in very, very early years, and the doses of tamoxifen were also different. Only 2 years of therapy was given, but taken all that together, the observed differential benefit suggests that ER agonist antagonist tamoxifen more efficiently prevents the late recurrences in genomic low risk, whereas the 2 year of goserelin, including the rapid systemic estrogen depletion more effectively reduces the early risk in the more aggressive genomic high-risk tumors. So this is the third study, the extended adjuvant aromatase inhibitors after sequential endocrine therapy, the DATA trial. So what this study did was that after completion of 2 to 3 years of tamoxifen, different periods of different durations of anastrozole therapy were given after tamoxifen. So it's a Dutch study. Postmenopausal women who were disease-free at 2 to 3 years of adjuvant tamoxifen were randomized to 3 or 6 years of anastrozole. Primary endpoint was an adapted DFS. This was calculated 3 years after randomization, and similarly an adapted OS. So 1912 patients were randomized. Median adapted follow-up time is 10 years. 10 years adapted DFS was 69% in the 6 years group and 66% in the 3-year group, with no difference in the adapted OS. So irrespective of the age, the tumor size, the patients did derive benefit, which was not statistically significant, but if you only see the cohort which had both ER and PR positivity, tumors which were more than 2 centimeters and node positive disease, the 6 years versus 3-year difference, the delta is 13.6%, and for the adapted OS, the delta is 8.1%. So the study did not recommend the use of extended adjuvant aromatase inhibitors after 5 years of sequential endocrine therapy in all women, but my take is that certain subgroups did benefit, and compliance issues with endocrine therapy, extended therapy, especially the musculoskeletal effects, should be thoughtfully considered. It may not be feasible for all patients, but yes, for those whom you want to consider, adjuvant bisphosphonate lifestyle changes are recommended to reduce the bone mineral density related effects. The fourth abstract is the 8-year follow-up of the ASTRA trial. This is adding ovarian function suppression to tamoxifen for young women with hormone-sensitive breast cancer who remain premenopausal or resume menstruation after chemotherapy. So the ASTRA trial did report the initial follow-up, and this is the additional 106.4-month median follow-up. And the initial study did tell us that 2 years of ovarian function suppression addition to tamoxifen significantly improves the DFS when compared to TAM alone for those patients who remain premenopausal after completion of their chemotherapy. So this is a post-trial follow-up. The primary endpoint was DFS and the secondary endpoint was overall survival. So even after 106 months of roughly 8 years of follow-up, there continues to be a statistically significant reduction in the DFS events, which is in the favor of the TAM plus OFS group. Estimated 8-year DFS was 85% in the TAM OFS group, while it was 80.2% in the TAM only group. No significant differences in the OS between these two groups, and the 8-year OS rate was 96% vis-a-vis 95%. So these are the previous curves, and this follow-up data is still in the abstract form. So here we can see that all the recurrence-free survivals were better in the TAM plus OFS group. The authors strongly recommend that there is a consistent survival advantage of adding OFS to TAM for these women, and definitely a longer follow-up is still needed to evaluate the OS benefit. My take is that these women who are less than 45 years of age have a higher risk of recurrence, and thus those who remain premenopausal or resume their ovarian function after chemotherapy should definitely be offered OFS for at least 2 years. Thank you.